I am delighted to be here again. I'm Maria Tilden from Care First Blue Cross Blue Shield. The first thing I have to do is thank our mayor, Mayor Muriel Bowser, for hosting today's event and continuing to shine a light on the importance of addressing maternal and child health in the District of Columbia, in our region, and across the country. The notion that she has assembled what is an extraordinary group and depth and breadth of people who are focused on this critical issue is absolutely amazing. 1,500 plus folks here ready and interested in playing an important role in addressing this problem. I also have to give a shout out to, and I don't know if she's here yet, but Mayor Pugh from Baltimore, Maryland, who we have worked with extraordinarily closely over the years in battling maternal and child health issues through a program called Be More for Healthy Babies, and hopefully you'll have an opportunity to hear about that later. I also want to thank the panelists earlier who gave so much insight and information into the strategies they're employing in Flint, Gary, and Rochester. Mayor Weaver, Mayor Warren, and Mayor Freeman-Wilson, thank you for taking the time to join us, and you will hear later from an amazing group of people, but I'm so excited for the balance of the day. As we all know, the United States has one of the highest infant mortality rates in the developing world. And despite record progress, the rate of infant mortality throughout the Mid-Atlantic region continues to outpace the national average. In 2016, Maryland's infant mortality rate was 6.5 per 1,000 births. The infant mortality rate in D.C. is even higher at 7.1 per 1,000 births, and the crisis is even more of a threat to black mothers who experience infant mortality at 5 times the rate of white mothers. We can also improve other indicators of infant health. In the district in Maryland, more than 10% of babies are born preterm, and in Northern Virginia, more than 7% of babies are born at what is considered a low birth weight. Additionally, maternal deaths in the U.S. have increased, as we discussed earlier today, with a recent analysis by the CDC finding that nearly 60% of those deaths were preventable. Improving our ability to provide access to health care for our mothers and infants could not be more critical at this time. And the mayor noted earlier today that the issue is not necessarily about coverage, particularly in the District of Columbia, because most folks are covered. This has the highest rate of insured residents in the country. And we need to address the access issue in education. For those of you who don't know, Care First is a not-for-profit health insurance. In addition to providing extraordinary high-quality care to our 3.2 members, we are also in the business of expanding access to quality and affordable care to the underinsured and uninsured. Maternal and child health has been our #1 area of focus over the past decade, here in the District of Columbia, Northern Virginia, and in Maryland. And as a consequence, we have invested nearly $18 million since 2008. And we will continue to make the investments until this issue goes away. Our funding has included focus on safe sleep facilitation, smoking and substance use cessation, expanded prenatal care service, treatment and maternal mental health, and others. We're also excited to share that later this year we will be announcing an RFP for further investments in maternal and child health. And so I encourage you mid-October to keep an eye and an ear out for more dollars to go on the street to help folks in this room and throughout the region address this important issue. At events like this summit, we are able to discuss unique challenges we each face as a community, but also the opportunities, and are very, very hopeful that these kinds of conversations can really make a difference. Together we can collaborate, share ideas and techniques, and offer innovative solutions that make a meaningful impact in the lives of mothers and infants. Again, thank you all for being here. Thank you all for sharing your ideas. Thank you all for making a difference on behalf of Care First. Thank you.
Hello. Would you please help me welcome our panel, the Honorable Mayor of the District of Columbia, Mama Muriel Bowser. Now, before I ask the Honorable Valerie Jarrett to join us, I know that you're eating, but can you give me 10 seconds? I've been to a lot of first-time affairs. I have never been to anything this large and this impressive the first time. Can we give the mayor a standing ovation? Please get up and thank this sister for caring about women. Thank you, thank you, thank you, thank you. God bless you. This is incredible. Look at this room. Look at you all. They had to add tables. They had to add chairs. The turnout is phenomenal. Now, if you will help me welcome the Honorable Valerie Jarrett, who has helped the president run this country. Not only no scandal, not even rumors about the Barack Obama family nor administration. The Honorable Valerie Jarrett. All right, now, eat like your mothers taught you, quietly. No loud chewing or clanging of forks so that everyone can hear us. Welcome, ladies. How are you?
Thank you, Cathy. Welcome to our summit, and thank you for doing this for us.
This is incredible.
I just have to say thank you so much, Madam Mayor, for this incredible crowd.
Yes.
Kathy, who says she hasn't done this in 20 years, we're honored to have her coming back and doing this for us, and I'm thrilled to be here with everybody.
Why? Why are you doing this? Number one, it's beautiful, it's classy, it's upscale, it's what the sisters in the District of Columbia as well as this entire nation deserve.
Thank you.
But why did you do it?
Thank you. Well, I think, and we heard on our earlier panel, and I think it's a goal that we should all aspire to, plan for, and invest in, because women in our nation should not be dying in childbirth. And that is and has to be our focus. And I believe I've had the privilege of being mayor of my hometown for almost 4 years, God willing, another 4.
And 4 more after that.
Perhaps. And then the way that we have knocked down what have seemed to be intractable problems is identify what the problems are, have an honest conversation about it, look across our nation for best practices, make the necessary investments, and be persistent about it. I think with political will and persistence, we can tackle this problem too.
You are doing an incredible job, and this is just one more indication. Now, Valerie Jarrett, as I said, not only did you go through 8 years and saw to it personally there were no scandals. You didn't even have rumors coming out of the White House. That's pretty impressive. You also chaired for President Obama the Council on Women and Girls. Tell us about that for a national perspective.
Well, thank you, Kathy. So I did have the privilege of chairing the White House Council on Women and Girls, and our goal was to make sure that in all of our programs, all of our policies, all of the legislation that we supported, we looked at it through the lens of, does this make life for women and girls better? And so every single agency in the federal government was represented on the council. First time ever that had been the case. And our goal was to engage people all around the country and hold up best practices for what works from prenatal to senior citizens in the lives of women and girls.
So, Madam Mayor, a lot of people really are not aware, and thank you for this conference, because so many individuals are here to find out what services are available. The District of Columbia has one of the best track records in the country in terms of services available. And you surprised everyone at Radio 1 when you said 92%, is it?
97%
97%.
insured rate in Washington, D.C., and we're very proud of that. And some of that we have to thank President Obama for, and making sure that everybody across the nation had affordable care. So thank you, Valerie, for that.
So am I correct with the addition of affordable care? Our numbers went up to 97% of all people in the District of Columbia have health care.
Absolutely. But what we know is it's not enough to be insured. You actually have to take advantage of insurance, and we have to connect our residents at every stage to a healthcare provider. We have to equip them with the knowledge they need to ask the right questions, to go to the doctor when they're having issues. And too often we see our people calling 911, using an ambulance, and using an emergency room. And we know that that doesn't lead to optimal health care outcomes for a lifetime. So I was very happy that our Department of Health included in everybody's program book all of the existing prenatal services, well woman services that we offer right here in D.C. And I think what we heard from the earlier panels, all of the other things we might think about adding or repackaging to everything that we're offering now.
I'm certain, Ms. Jarrett, that this has to be very rewarding to you to see this first annual conference. And we say first annual, which means we'll be back next year, correct?
Well, we said it was inaugural, so I
All
think
right,
exactly. It means there's a second one coming.
So this is an outgrowth of the White House Council on Women and Girls.
Well, it makes me so proud, to tell you the truth, to see all of you here who care so much about this issue. And we're fortunate to have the mayor's leadership, but she can't do what she's done without everybody helping. And so to see this tremendous outpouring of interest from people who are in the trenches each and every day working on this is so important. And I would mention to you that one of the benefits of the Affordable Care Act, as the mayor mentioned, was having these abilities to register so many people and ensure that they have access to affordable health care. But also an important benefit in the Affordable Care Act is the research dollars that we made available to study health disparities in communities of color. Because we know across our country, not just in the District of Columbia, there are extraordinary health disparities. And what President Obama wanted to do was to make sure we were doing the research to analyze these disparities and the solutions. So a lot of the work that the mayor is doing here in Chicago provides the foundation to do the analysis that needs to be done and to hold up best practices for what actually works. So in every city and town across our country, we can begin to improve health care for women and infants.
Now, we're not going to let you steal our mayor. You said of Chicago. We're keeping her right here in D.C.
She has the Chicago
and we're keeping
and
we're keeping you too, and the Obamas.
Chicago's on my mind. I'm sorry.
If you move here, you stay here. That's the rule.
But Cathy, could I add? There's no mistake that we are hosting the conference today at the start of the Congressional Black Caucus, and I know our Congresswoman was here with us earlier, who's chairing this year's convention. It was important to me to invite my colleagues, fellow mayors, to be involved in this conversation because we're not unique in D.C. We're not unique in saying we're not satisfied with our outcomes for women and infants, and there's work to be done. And I think just at the mayor's panel earlier, I learned some things that my colleagues are doing. We're joined at the luncheon by my colleague from Baltimore, Pugh, and we shouldn't have to remake the wheel with every program or service. But we also have to call on the federal government. There are things that we can do locally. We are privileged in D.C. We're a city, county, state. We have $14 billion of a budget, and by many measures, this is the most prosperous of times in our city. And so that's why we have to expect more and do more with our investments. But we also need national policy. Somebody stopped me earlier at an earlier panel and said, you know, Mayor, are you all going to talk about paid family leave, for example? And are you going to talk about child care, for example, because these are things that impact how families approach childbirth in the year after, and that's so important. Now, we're going to be moving a paid family leave policy in our city, but we're also burdened with our own policy to support Maryland and Virginia. Wouldn't it be better if we had a national policy for paid leave so that that one municipality is carrying in the weight for a whole region? So these are the types of the discussions that we hope our lawmakers at the national level continue to advance for women and girls.
That really, it brings my next question about Valerie, because oftentimes a city will have a great program, a great initiative, but it's in conflict oftentimes with securing funding or even approval from the federal government. What advice can you give us on how to bring what we want to do in line with what the current federal government wants to do?
Well, that's a hard question. No, but look, in seriousness, the point that Mayor Bowser made, an important one about paid leave, and paid sick days as well, as we are the only developed country in the nation, in the world, the only developed country in the world, let me say that again, that doesn't have a national paid leave policy. And so, yes, what you're absolutely right, Cathy. What that means is that it's patchwork. And so there have been cities around the country that have passed a paid leave policy. There's something like 43 million Americans that don't have a single paid sick day. That's stunning when you think about it. So we do need national policies. And so I think what I encourage is leading by example in the way the mayor here and mayors across our country are passing these individual pieces of legislation in the hopes of demonstrating what we all know, which is that it's not just good for working families to have these policies, it's actually good for business and it's good for the economy. And we will have a healthier society when we recognize our individual and collective responsibilities to take good care of our women and their children. That's good for everybody. So I encourage you all to, thank you, to show what works and to start to build some momentum. And to really, I can say this now that I no longer work in the White House, I can tell you to lobby. You have to make a real effort to lobby your members of Congress and explain to them why this is so important to you. Tell your stories. We've heard those stories. Share them with the people who represent you.
Do you think that things will change now that we find more women seeking and achieving public office?
I absolutely do, and thank you for mentioning that. We know when women are at the table, these issues are on the table, carefully considered, thoughtfully considered, and can advance. And we know that women can form the types of coalitions among their colleagues or across states that make them work. And I think it's exciting to see more women running. Doesn't everybody think it's more exciting to see women running? And at every level. And I'm privileged to be, when I became mayor, I think I was one of 4 or 5 African American women who were mayors of big cities. This year, that changed. Many more African American women are leading big cities in Atlanta, Louisiana, in Charlotte, who's in our prayers. And so we have the opportunity to speak for and represent millions of people in education and public health and criminal justice, the issues that are really affecting our community. So we have the opportunity to make sure that we're supporting women in office and then holding them accountable for the issues that are important to us.
And many of them are participating in your inaugural conference.
No, absolutely. I think you know that I've been active with the African American mayors and active with the U.S. Conference of Mayors, and we really, it's a coalition of mayors, and President Obama was very active with mayors. I think he realized that if you have a Congress that won't listen to science or won't listen to the things that make sense for cities, then you take that conversation directly to the mayor's offices. Then we appreciated that relationship a lot.
So we have been really applauding, and rightfully so, and singing the praises of what the district is doing correctly. What areas, Mayor Bowser, would you say that we need improvement in the district?
We absolutely, and I think Dr. Nesbitt is going to be talking to a panel of physicians. We want every part of our city, all 8 wards of our city, to have access to high quality care. We have, over the last years, made huge investments in our primary care network. So with a highly insured population, a lot of primary care doctors, we know that people should have a medical home. We have more work to do with specialists, OBGYNs in all parts of the city. And we want a family not to have to pass by their neighborhood and 2 or 3 other neighborhoods to get to the doctor that they want and trust, to go to the hospital that they want and trust. And so we announced just a few weeks ago that we've entered negotiations to build a new hospital in Ward 8, and we want to make sure that
All right, let's hear it for a hospital in Ward 8. That's mega.
It's
Thank
major,
you.
but it's not enough. It's not enough to build a hospital, right? Because that's at the end of the spectrum of care. We want to make sure that their doctors in the neighborhoods in Ward 8 and Ward 7 that will work at that new hospital, and that there are residents who will go to those doctors who will work at that new hospital. And I always say this, Sibley is not the hospital for Ward 3. It's the hospital for Washington, D.C. And the same will be true for the hospital we build in Ward 8. It won't be the hospital for Ward 8. It's the hospital for the whole city. And so we have to build and make sure that there are services that attract any and every doctor or Washingtonian.
Let's talk about the interaction that's required both on the federal level as well as the local level between the various agencies, because it's just not help. It's the police, it's housing, it's education. Let's start on the federal level. Who did you have to really bring into the fold to get accomplished what you all were able to get accomplished during those 8 years of the Obama administration?
Well, it was President Obama's view that all hands on deck. And so, for example, his Domestic Policy Council, that was comprised of cabinet secretaries from every agency that deals with issues of domestic policy, would gather together, and we would work holistically to see how we could improve the quality of life generally. And so you're right, it's not just maternal health. It's making sure that people have a good education, making sure that they have an affordable place to live, making sure that our streets are safe, making sure that they have parks and recreation, making sure that all of the issues that are important to quality of life are being concentrated holistically at the federal government. But President Obama didn't stop there, and Mayor Bowser mentioned this. Our partnerships with our nation's mayors and governors were very important. And one of the responsibilities that I had was being the liaison to the mayors and governors. And the reason why was because you can't ask the federal government to do anything in a vacuum. We learned a great deal by talking to our nation's mayors about what were the issues that were important to them and to their constituents. How could we partner? How could we leverage federal, state, and local dollars to make an impact on your lives so that we weren't operating in these silos, which is often a tendency in government. And so those partnerships, I think, were very rich. And then we had to bring in the philanthropic community, our foundations, as well as the private sector. And that when we did that, when we had that holistic approach and when we really included everybody to be a part of the solution, that's where you have the biggest impact. And then the final piece I would say was so important to us is data and evidence. And we were science-based. And a lot of that information came from the hard work that is produced at the local level. So it's cooperation, it's partnership, it's leveraging dollars, and it's including both the private and the philanthropic community along in those efforts and sharing all of that information in a transparent way so that we can take what works to scale.
And I think that continues to be very important to the work that my department will do with federal HHS. And we are always looking for ways that we can get the most dollars. I think everybody knows that in D.C. we're actually a donor state. We pay more to the federal government than we get back, yet we don't have 2 senators voting for us, and that has to change.
Please say it again.
That has to change.
Absolutely.
And so that healthcare dollar can be leveraged in a lot of ways, and we have some really smart thinkers about the monies that we're getting back, the federal Medicaid and other ways to help support all parts of that kind of healthcare chain that leads to somebody having a quality doctor and a quality hospital experience.
You mentioned a name earlier, Dr. Nesbitt.
Yes.
Please tell our audience about Dr. Nesbitt.
I would be happy to. So Dr. Nesbitt is our doctor. And my approach when I became mayor, and we've had great DOH directors, don't get me wrong, we really have had great DOH directors, but I didn't want our doctor to be just a manager of an agency. I told her she was the face of public health for Washington, D.C., and I wanted her to be out in the community talking about everything from fitness to smoking cessation to eliminating all of these chronic diseases and making sure that people were managing, I should say, chronic diseases. And that is the approach that we have taken in our health department. Dr. Nesbitt and our team have created the Healthy People 2020 plan for Washington, D.C. that includes all of those things, including how we mitigate the AIDS virus in our city and all of the things that can affect one's quality of life. What we believe is that you can't experience great education and you can't experience all of the qualities of life that you expect in our city if you're not healthy. And so we start there, and we believe in health in all policies. And to your point about women and girls, we look at everything we do, from procurement to buildings to hiring, to see how people can approach how DC residents can become healthier. The bottom line is we make huge investments in our health. We should have better health outcomes. And I think I shared with you the other day, I get the opportunity to go to a centenarian luncheon every year. And every year that luncheon gets bigger. Okay? We have more people in our city that are living to be much older, in their 90s, and more 100-year-olds that are living in our city. Many of them are living on their own. And I say to everybody, when you get that age, don't you want to be able to walk? Don't you want to have all of your limbs? Don't you want to be able to see? Don't you want to be able to choose to live in your own home if that's what you want? But to get to that outcome, all of the decisions that we make about our health will determine that. And as a mayor, and that's also a bottom line issue for us. We want people to live long, but we want them to live well and live long. And so that's part of our Healthy 2020 plan.
I want to shift gears because one of the things the three of us have in common is a lot of responsibility in our professional life and our family life being our number one priority. One of the issues that I hear a lot of women talk about is this whole issue of child care and help so that they can pursue a career, so that they can, in fact, be fulfilled as a woman executive, a woman professional, a woman artist, whatever they so desire to do, but at the same time want to make certain that the children aren't the sacrifice that they're making. I hear women frequently say, I don't have time to go to the doctor. By the time I finish with my career and come home and take care of my children, how are we balancing that? And I want to start with you, Valerie, because certainly I think that you and I are a little bit older than the mayor, not a lot, but we've been there, done that. She's just starting with a brand new baby Miranda. I'm the new babysitter. I've signed up for it. Okay.
It's a very good question, Cathy. So I was a single mom. My daughter is now, I should say still am a single mom. My daughter's 32. So yes, I've been through some things, but I was a single mom with resources. I was a lawyer. I had the same caregiver for my daughter from the time she was 3 months old until she went off to college, and then she started taking care of me and my parents. So she was a part of our family. I could set my watch by what time she walked in the door every single day. It was affordable for me. When she wasn't available, my parents were available. And I still felt like I was hanging on by my fingertips, trying to balance my work responsibilities with the most important thing in my life, right? And so if I was hanging on by my fingertips, what's it like for that single mom who's working 2 shifts and has no support at home and can't afford quality child care? And Mrs. Obama used to say, don't we miss Mrs. Obama, by the way?
Yes.
Oh, yes, absolutely.
But she used to say something that every mother in this room will appreciate, which is that if you're worried about your children, you can't breathe. And so many of our moms leave our children in harm's way because we have no choice. And you just cross your fingers every day and hope that they're going to be okay. Our country should be able to provide affordable child care for every single child in this country. We shouldn't have to choose. I meet a lot of women who don't work, not because they don't want to be back in the workforce, but because child care costs more than they would make.
That's right.
It is cost prohibitive, and so we have to figure out a way, and President Obama had proposed ways of making child care much more affordable, and that needs to be a top priority across the country, and it would help to have a federal policy that would make it more affordable. So I think that one of the challenges we all have is trying to figure out, we're not superwomen. And our generation, Cathy, we thought we could do everything the guys could do, plus be traditional moms and spouses and all that. And I say to the younger women, I'm so happy that you realize that you should have partners who will help you do some of that stuff.
Absolutely.
You shouldn't have to be doing it all by yourself. But the minimum that you should expect from your government is to make it a little bit easier for you. Those of you who are struggling shouldn't have to struggle so hard. Our children would grow up healthier if they had quality child care and early childhood education. And there are great programs in the district like EduCare that are doing that, but not every single child has access to it.
So, Mayor Bowser, was that something that you pondered before adopting, how you could really balance this whole issue of leading the city, the number 1 city in the world, and being a good mama?
Well, you could put me in the category of hanging on by my fingertips. And I do have a lot of resources, and while I plan for it, I don't think you really know until you know. But it's so worth it to figure it out. And so I think that's what so many people come to. And so I did think about it. And one thing I know about our city, we are, and I tell my staff, we are an amenity-rich city. People are coming here, 900 people per month. We are 700,000 people in D.C. now, and we haven't been 700,000 people since I was born in the early 70s. So we have grown fast over the last 10 years, which means everything is more expensive. Housing is more expensive, transportation, food is more expensive, and childcare is incredibly expensive. Many families in D.C. find that they're paying more for childcare than their housing costs, and their housing costs are already high. So we regard it as the right thing to do to figure out how to make childcare more affordable, but it's also necessary if we're going to continue to grow as a city. Young families won't move here if they can't find affordable childcare, affordable housing. They're going to look to other cities that are more affordable to move to. And we want young families. We don't want to be a city of the very rich, and that's all that can be in D.C. We want to be a city where everybody along the spectrum and along their lifespan can afford to live. So some of the things that we have put in place as we've been focused on this is making sure that all the resources we already have are accessible, so you can find out, so you can go through our Thrive by 5 DC website to find that out. We are investing in our child care workers. because we subsidize a lot of child care, and we want to make sure that that child care is quality. So it's not just going and having a kid sit down and look at TV. It's the kid going to learn. So by the time they get to pre-K, they are ready to learn. We have for a number of years invested in universal pre-K in the District of Columbia. That's free school, by the way, starting at the pre-K 3.
You like the word free.
I like free
today's
school.
activity. We like the fact that you like the word free.
And it's not, it's free, but we have decided as taxpayers that that's how we want to invest our money.
Yes.
And so that's important too. And so we are also looking for ways, and this is one very good federal program that we're emulating. I was actually, I think at the last state dinner, I was invited. Thank you for that. And I was sitting next to one of a White House staffer who was telling me about her child care experience, and that she was in a federal program, that their waiting list a mile long for these federal programs. And it was that the federal government, various agencies, make space available in their buildings or in nearby buildings. And whether you're at Justice or you're at the FDA, you can sign up to have your child in one of these facilities. The feds hire high quality operators, and the parent is close to their child during the day. And I said, we can do that. So just last year, we started a program where we identified DC government space. We have 3 in the works. We're hiring high-quality operators, and we are making that space available to DC residents. And we know we can do more about that, because that helps to drive down the cost of child care.
So, Valerie Jarrett, you're probably, next to the Obamas, the most sought-after speaker on the speaker circuit right now. Why did you choose to take the time today to come be with us?
Oh, that's an easy question, because I want to be a part of what's working. And what Mayor Bowser is doing right now, at a time when so much is not working, let's face it, I wanted to associate myself and help lift up what is absolutely so imperative for people in our community. And I think that what's happening here in D.C. is really a beacon of hope around our country. And I wanted to come here so I would feel better. It was for selfish reasons, too. I knew you all would make me feel good, so I can go back out there and I can talk about what works. And I do, and in all seriousness, we have very good reason to complain about what's not working in our country, but there is a lot that is working, and we can learn from what does work. And it is just one example of what's happening here in D.C., which we haven't mentioned yet, is your One Key Question initiative, which is so important. The one key question is, do you plan to have a baby this year? And if you answer that question, then it triggers a whole host of ways in which you can prepare for that very important event. And so that's something that every city across the country could just emulate tomorrow. And so coming here and finding out what's happening and being able to lift it up on the national, put a national spotlight on what's happening right here in our nation's capital, and to take the stories that I've heard today as I travel around the country and help encourage other people to follow Mayor Bowser, your lead.
Thank you.
Mayor Bowser, I've been given the signal from your staff that the next panel is almost ready to start, but what was your personal goal and mission to be accomplished today with this inaugural conference?
Well, my personal goal is that people in major cities across our nation are talking about maternal and infant health, and talking to their local officials, talking to their Congress people, so that this message is on the tips of everyone's tongue. There's no reason why women should be dying in childbirth in the United States of America.
Absolutely.
And so as we have that as the topic of discussion, we can leave all of our panels today with a set of best practices that we've collected in actions. Dr. Nesbitt will convene a follow-up session in October, so we can gather what we've learned and set out an agenda to move forward. And it may be that this, I'm thinking more and more as I talk that this is an initiative that we will have not just every year, but we will put together a group that helps us follow this information and make some recommendations. My colleagues in the U.S. Conference of Mayors have endorsed a resolution to keep this on the top of a national agenda, and I know that they'll put their lobbying efforts behind it too.
Mayor Muriel Bowser, we thank you.
Thank
we
you.
thank God for you. Valerie Jarrett, thank you. May we have a rousing round of applause for our panel. And we thank each and every one of you for being here. This turned out incredible.
Before we get started with this awesome panel that's about to approach the stage, I think we should give those incredible women another big round of applause. I shall be before you for only a few minutes, but I wanted to take a moment to give a real shout out. She gave a shout out to me. I'll give one out to you. Maria Tilden, Care First. Thank you so much for all the work that you do and for all that you've done, not just in Baltimore, but across this country. I know that you serve Washington as well, but the voice that you lend to healthcare has been awesome. Thank you so much. Blue Cross Blue Shield. And let me also say again to Muriel Bowser, the mayor of this great city, thank you for this invitation. I consider her my sister mayor because she's right down the road, and we've got another little sister in between us in Prince George's County, Ms. Alsobrook, who I predict is going to just do really great things for all of us. Let me just say a few things. One, I think the information that has been shared with all of us certainly is important to all of us. But the thing that I want us to remember is that we're coming from across this country. And when you talk about family leave, the health of our babies, we ought to be taking those messages back to our states and making sure that we are passing legislation that make it advantageous for all of us to be able to provide health care and family leave in all of our states. I also want to talk a little bit about Be More Babies, Be More Healthy Babies in Baltimore, because like DC, we are trending downward in terms of death among our babies in early childbirth. And I'm really excited about what we've done, and I would hope that all of us would know how to connect or try to connect with our healthcare organizations and our area hospitals, because they can be tremendous partners in terms of how we deal with health care and the health care of our babies. One of the things that I really like about the program that we put together is its connection in the community, utilizing your churches. Maria, I was sitting in church on Sunday, and I noticed a fan that talked about are our babies sleeping correctly? Does anybody know how our babies should be sleeping? Absolutely. On their back alone. On their back alone. And oftentimes, you know, as mothers, you want to cradle that baby, and we will end up smothering them. And so we want to make sure that that message gets across to all of our young women. And the other thing that we've been very successful in doing in Baltimore is reducing teen pregnancy almost by 50%. The thing that is also important, you all, is that we have to connect with our health organizations, because I'll never forget a story that was told to me about young children in school who were labeled hard to learn. And we had connected with one of our healthcare hospitals in our city to just check the eyes of our children. And what we found is that many of those children were labeled hard to learn because parents are so busy that they didn't even take them to get their eyes checked. And if you could have seen the faces of those young children when they got their first pair of eyeglasses, because that's all they needed were eyeglasses, it was unmeasurable. So I ask you all to also consider, when we're dealing with our young children, that we make sure they take care of their eyes and their teeth. Because in Maryland, we experienced the death of a very young child because the parents were not taking care of that child's teeth. So we want to make sure that we're taking care of the whole child. And the other thing is, in Baltimore, we have many Judy Centers. How many people out there know what Judy Centers are? Absolutely. Judy Centers are organizations that start educating our children at 6 weeks of age. 6 weeks of age. And to the extent that we begin to educate our young people at their earliest age, it changes the trajectory of their lives. And so I'm excited about the work that we're doing. I'm excited about the partnership that we have with Care First, Blue Cross Blue Shield. We have some of the greatest hospital systems, and I know our doctor of Washington, D.C., talked to me about the fact that she is still, I believe, a faculty member at the University of Maryland Medical System. And both of us remember when it was one hospital, and now it is a 14-hospital system. And so we work very closely with our university hospital, as well as the #1 hospital in the country, Johns Hopkins University. And so, yes, we can give that a big round of applause. We, too, are very proud of the work that our health department has done, because it is the connector between the mayor's office, the community, our healthcare organizations, and our hospital systems. And so we must all recognize that we can help each other to improve the lives of our babies and our children. So again, I'm looking forward to the next panel, but I just wanted to share with you all that this is a great first start. And I think, as the mayor has said, this is something that will continue. Again, I thank her for asking me to co-host this with her. But more importantly, it's the work that we do when we leave here. And it's how we share with each other best practices, opportunities to engage, and more importantly, how we make sure that our young people, our babies, grow up to be productive members of our community. Thank you for this opportunity to share.
Good afternoon. My name is Pamela Riley. I am Medical Director for the DC Department of Healthcare Finance, and I am fairly new to DC government, but as a pediatrician, these issues have long been a priority for me, so it's a pleasure to be here on behalf of the Department of Healthcare Finance. As DC's Medicaid agency, we have a tremendous responsibility since we provide coverage to a quarter of DC residents, and with that comes a tremendous responsibility for ensuring access to health care as well as improving the quality of care for DC Medicaid beneficiaries. But we also know that as an agency we can't do that alone, which is why on behalf of the Department of Healthcare Finance, I'm very happy to be here with all of you and thank Mayor Bowser and Dr. Nesbitt for the invitation, and look forward to participating in additional efforts with other city agencies, with healthcare partners, and with community members to really improve healthcare and health outcomes for our moms and babies. So we've heard a lot today about a lot of the social, economic factors, a lot of the environmental issues that impact healthcare and health outcomes and perinatal health. But we also know that it really matters what happens once you get into the door of the healthcare system. And that's part of what we want to talk about with our panelists today. And we have seen time and again that access is important, but it's not sufficient. What it really matters, the standards of care, the quality of care that's being provided to moms and babies in order to ensure better health outcomes and more equitable health outcomes for the populations that we care about. So that's what I would like to discuss with our 4 panelists today. We will hear more about them. We have 4 physicians here who have years of expertise providing care to moms, to pregnant mothers, about what the standard of care should be that all moms should be receiving. as part of perinatal health care. But these, much like us, all of us here, these physicians know that the healthcare system can't do it alone. So we also want to hear from them about the role that forming partnerships has played in their work to really achieve the goals of providing high quality care and improving health outcomes for pregnant moms. So with that, my first question is for Dr. Melissa Freese. Melissa, Dr. Freese, you have a lot of experience, years of experience, both in your role at MedStar Washington Hospital and providing direct care as an OBGYN. Can you give us an overview of what should happen when a woman's pregnant? What should that care look like? What are her next steps when she finds out that she's pregnant? And specifically when it comes to health care, and why is the quality of that care so critical?
I think that's the critical question for all obstetricians to try and define. And it is a rather hard one to summarize in a small space of time. I would say the first thing that the mother who finds herself with a positive pregnancy test is she needs to look at what are her habits that she can quit. Can she stop smoking, stop drinking, stop smoking weed? Can she wear her seatbelt? All of these things that are really healthy things. I think that then you have to look at what is her underlying healthcare concerns. Because while institutions like MedStar have adopted some of the large packages to control some of the major risks, like hemorrhage and hypertension and thrombosis, they're not enough if that's all we're doing. We have to look at their overall health care of the mother. So I feel like once that is established, then the woman needs to seek out the best provider for her. And I am really blessed at Hospital Center in that we have a full capacity of resources. We have an amazing midwifery program for handling mothers who are seeking that health care. We have then an amazing cadre of extraordinarily high-risk physicians who can handle everything from cranial wounds in pregnancy to gunshot wounds to the most challenging deliveries of all. And so if a mother knows she needs that care, then I feel like that's the next step she should seek out.
Thank you. My next question is for Dr. Dana Smith. Dr. Smith, as a maternal fetal medicine specialist at Kaiser, can you tell us a little bit more about what happens at Kaiser in terms of efforts to improve the clinical quality of care for pregnant women?
So, thank you. I just wanted to take 1 second just to thank you for the invitation to be present at this conference. The advertisements for this conference were amazing. Just last week, I had 2 patients come to me and say, Dr. Smith, I'm getting ready to deliver my baby, and I've heard a lot on the news about maternity care and the state of maternity care in this area, and what can I do to not die, quite frankly, having my child. And that's the first time that I've had in my career patients come and ask me that question outright. So I just want to say thank you for that first. So at Kaiser Permanente, we focus a lot on coordination of care as well as prevention. And so what we have found is that you have to have a systematic way to identify high-risk health behaviors and a systematic way to identify high-risk medical conditions that will adversely impact a patient's pregnancy and ultimately delivery. And so if you don't have a system in place to identify those patients, then people fall through the cracks and get missed, quite frankly. So we have instituted and have had up and running in the past 2 years really what we're calling a comprehensive perinatal program. It involves perinatal case management, an early start component, as well as something called the Perinatal Service Center. And these 3 components of the program are really integral and work together to help manage some of our highest risk members. So the case management program is in place to help women that might need access to stable housing or have problems with intimate partner violence, which I don't think has been stressed, quite frankly, in this conference just yet. Food insecurity or transportation barriers. Maybe they need help with transportation to and from the medical clinics. So we have licensed social workers that are present to identify those patients either through referrals or through alerts through the electronic medical record, and they have an ongoing relationship with the patients throughout pregnancy. The Early Start program, we have a PhD trained counselor to help women reduce risks related to either the desire to quit or reduce exposure to tobacco, alcohol, illicit, and prescription drugs. And so she also receives referrals on a weekly basis, either directly from the provider or through alerts through the electronic medical record to manage patients throughout the entire pregnancy. And then finally, the third component of the program is the Perinatal Service Center. So we take all patients that have had a history of preterm birth or at risk for preterm labor in this pregnancy. We take all patients that have a history of hypertension or hypertension complication in this pregnancy. We take all patients that have diabetes or a history of diabetes or diabetes in this pregnancy, and they are enrolled in the Perinatal Service Center. We have high-risk obstetric nurses. Many of you may know some of them. They've had a lot of experience on the L&Ds in this area and working in maternal fetal medicine offices in this area. And they are assigned a caseload of patients. They contact the patients every single week. And we strive to see if we can help the best practices that we already know get carried out in this patient population. So 17-hydroxyprogesterone, cervical length screening, every patient gets a free, no-cost blood pressure cuff. You know, they're expecting to provide their blood sugars on a weekly basis. So that's our catchment program for identifying some of our highest risk members. And number one, getting them into care, educating them, supporting them throughout the pregnancy, and then following them through the postpartum period. The medical record system helps tremendously. So we can have video visits, we can have telephone appointments, so you can come into the clinic, you can upload your values, on your phone, whatever works for you as a patient. We strive to help you meet goals in that way.
Well, that's very encouraging to hear that there's that effort of coordination across the spectrum of care, both before, during, and after birth. Is this a program that is specific to Permanente Medical Group in Maryland, or is this implemented more broadly across Kaiser?
Correct. So this program has been implemented and been running in the California Kaiser region for quite some time. We have been up and running in this region for approximately 2 years.
Thank you. I will now turn to Dr. Audra Meadows, also a physician with extensive experience both providing direct care to pregnant women, but you also have a lot of experience in statewide efforts to improve perinatal health outcomes. And I'm just wondering if you can share with us, what does it take to make those types of efforts work, efforts that are really focused on improving clinical care, but that also involve a partnership aspect beyond just the healthcare system? And what do you do to engage not just healthcare providers, but some of those other partners as well?
Sure. Thank you for that question. The work that I do as an obstetrician and as a public health care provider, I think about the fact that a woman, when she's pregnant, should not have to know what hospital can I walk into and have the best chance for a good birth outcome. They should just be able to go to their local clinic, their local hospital, and have just as much of a great chance of having a good birth outcome, a good birth scenario as any other place. Safety is not where hospitals should compete. So some of the work that we do with the Massachusetts Perinatal Quality Collaborative is we work with the hospital systems to put in place something that was mentioned earlier in the conference about safety bundles. Some of the work that we look at involve hemorrhage, hypertension, cesarean rates, especially among those who are low risk for cesarean in the first place. And so when we do that work, it's pretty straightforward in terms of the type of QI work that's being done. We offer technical assistance, there are checklists, there are bundles. It makes pretty good sense as to what to do. But to be able to do it, the relationship is probably the most important, to make sure those partnerships happen and that they work. The work that we do often is among a lot of folks who are volunteering their time within their hospital system to make these things happen and to make them work. And when we're doing that work, we support each other. We get on the phone, we make calls, we answer questions, we lower down those walls. We don't want to exist in silos. We want to get the work done so that women can have great birth experiences. Medicine is a team sport. This has to happen across all levels of everybody being involved in the care, from the person you meet when you step onto the labor and delivery unit, all the way through everybody you're going to meet during that experience. And so we work with those in that capacity to make sure that everyone knows what role they play on that team, and that, in part, some of the bundles explain that. But I would say the key ingredient to that are the partnerships and relationships of those partnerships to build trust and to build collaboration and to work and support each other. This has been happening a little more across the country in the last 5 to 7 years. State perinatal quality collaboratives have been popping up in most states, and they're growing. And so that's really encouraging. Nationally, the National Network of State Perinatal Quality Collaboratives is there, funded by the CDC and supported by the CDC to do some of this work through NICHQ. So we have an infrastructure that's growing and developing to help people and help systems and hospital systems and folks interested in doing this work, especially possibly in the District of Columbia, to do this work with the hospital systems. So the infrastructure is there. But despite the infrastructure, everybody's busy. Some people are at capacity, and so some things you'll look at is readiness. Does the hospital system or the clinical space have the ability to take something on? And once they have the readiness and identify what the issues are and areas they want to move on, maybe it's all of them that we talk about, maybe it's one or two, maybe it's opioid use disorder, maybe it's looking at preterm birth prevention, maybe it's looking at hypertension, hemorrhage, or cesareans. But whatever area you dive into, that readiness is important, that ability to observe the problem and report that, and the systems to be able to see if any changes you put in place lead to an improvement are important as well. But the key ingredient definitely are the relationships and staying connected with one another.
Thank you. And finally, Dr. Hugh, my question for you is, given your breadth of experience working on clinical quality improvement initiatives, both in your role at Howard as well as in your previous roles in Louisiana and Maryland, you bring a lot to the table. From these different experiences, can you tell us a little bit about what's required to get a lot of these cross-sector projects off the ground to really improve quality of care?
Well, make sure it's on. Again, thank you everyone for being here. This is an amazing gathering. I think the first thing to look at is to identify that regardless of what the goal is finally in terms of quality of care, the outcomes, is that the populations that we deal with can be so very different. They're not homogeneous. They're very heterogeneous. We have different languages, we have different cultures, we have different beliefs, and trying to harness sometimes for the goal of good outcomes requires a multitude of ways in which we tackle them, and that's still today true as it was in the past. And so trying to drive towards that means to identify not so much from the hospital side, not with the bundles and everything else that we need to do, but from the community side. To really affect outcome in pregnancy, you've got to get there early. And to get there early, you've got to engage communities. And engage your communities, remembering that, again, from my perspective, I'm a high-risk obstetrician also by training, but pregnancy is not a disease. And so we have to start with the fact that it's a community and the community of women that count, and engage in that resource is really, I think, the most important thing in terms of pregnancy. And then that resource can help you to identify where the risk is coming from. Many times by the time women come into our system and risk is identified, it's identified at the hospital level where it's really kind of too late. I mean, we can intervene in our medical way, but if we can intervene earlier by identifying that risk pool earlier, then I found out we were able to at least have better intervention. And so from a quality perspective, I always say we've got to keep reaching backwards in pregnancy, starting in the community and intercept them before they get to the hospital level.
Thank you. And what are your thoughts on what can be done to better encourage some of those hospital community partnerships? I think we all are in agreement that it's important, but how do you actually make it happen, and how do you sustain it?
So I'll point to the thing that we're doing right now at Howard since we've been there is we've formed an alliance, for example, with Unity Health Care. And Unity is spread across the wards in D.C. They're in the community. They're the primary providers of care. They have midwives, they have physicians. We, on the other end, are basically, from Howard's perspective, very much hospital-based, getting them to help us and us to help them have continuity of care. So if I took D.C. in and of itself and look at what I saw in the first 2 years when I first arrived, there's a lot of discontinuity with women who don't really know where to go to deliver. So they go multiple places to get their prenatal care. And they may show up at MedStar at Washington Hospital Center to say, okay, I'm here to deliver. But there's no relationship, there's no continuity. We don't really have a good feel for that record. So I think one of the things that we're trying to build is a continuity of care that starts from the moment they're seen all the way through. And so even if they come into the hospital system, we can identify the providers to whom they return, and we can track them throughout the system. So again, it's trying to manage not only access, but to manage and get the patients to understand that you do have a home, you do have a process that you can follow to be less confused. And that's so much more important, where I've had the experience of just seeing so many people from different backgrounds and different cultures who come into our system, and we don't have all the expertise that we need at the hospital level, but the community has it to help us to do that.
Thank you. My next question is for all of you. If you could each tell me what are the top recommendations that you would have for this group as to what needs to happen either at the local level, state, national, in terms of either policy interventions that we can start to consider that would really make a difference in terms of improving health care and health outcomes, maternal and infant health outcomes. I'll start.
Another small question. I think that it's really important to look at our guiding groups, such as the American College of OBGYN and the Association of Women's Health and Obstetric and Neonatal Care Nursing, to look at what those groups have put together as guidelines for initiatives. We've all talked about our bundles of healthcare provisions and similar policies that have been established in California, and other policies such as the Safe Motherhood programs that they've had. Those are initiatives that can be imported into pretty much any hospital system, and particularly across a city like ours, which is a very diverse city, but it's not the world's biggest city, thank God, and therefore we can get to know each other well and know each other's strengths and abilities. So I would say utilizing on a national level those guidelines, implementing them across the city, but then looking at our regional strengths and abilities to meet the needs of our patients is the critical piece. And I really believe that much of our health care is in the early prenatal piece. Our hospitals handle the end product. But unfortunately, many patients feel like the end product is all that matters. And if you've got some concerns in the health, that's not going to be the way that you can get the optimal care for you or your baby. I think also we need to build some additional policies that are unique to us in a city. Our concerns for preterm birth, our concerns for preeclampsia. We have one of the highest rates of preeclampsia, high blood pressure and protein in the urine during pregnancy that I've ever seen. And that has long-term consequences for a mother's health. A woman who's had preeclampsia in her pregnancy has about the same increased risk for cardiac disease than if she were a smoker. And that's huge. So some of those things are ones that we have to look on in addressing how we can meet our regional needs, but I think it can be done collaboratively. And our recent challenges with Providence Hospital in incorporating those deliveries across the city has made us all much more collaborative.
I would say also that collaborative approach is really important. What comes to mind is, first, it cannot go without being said that when a woman approaches the clinical care setting and the hospital system or outpatient clinic, we can do everything possible to optimize her care, but a lot of the driver of what's going to make her outcome the best belongs in the area of the social determinants. So having that relationship with the agencies that address the social determinants of health is key. So maintaining that is important, but having it be visible in a very formal way between the hospital systems, clinical systems, academic hospitals, university systems, and your public health department makes sense. And those would allow people to know where they can be impactful in collaborating, because I think those lines aren't always very clear in every city. The other thing that comes to mind is that when a woman does walk into her healthcare system or into the clinical site where she wants to get her prenatal care, it should be set up such that it's the care that she wants. So I think about, someone mentioned earlier, I believe Stacey Stewart from March of Dimes, about group prenatal care. Is the system set up so that the patient can walk in and have the kind of care support that she'd want if she were able to be in group prenatal care versus individual care? Are the options there for education? There are lots of products on the market that are starting to develop that are technology-based to help educate women for their pregnancy. Some are very distant from their clinical system and their provider, which is fine because they still give very good information that's provided by a lot of our national agencies. However, to have them that are more closely connected to their providers are important, and I think that there are some technology companies out there working to do those types of things, but that hasn't really come to the forefront in medicine yet to be able to better help the providers also connect to patients in that regard. So with community connections, dealing with social determinants of health, with an infrastructure and a system set up such that women can get the care that they want, whether it be group care, traditional care, education through technology, et cetera. I also think you want to consider system for conversation. So in that regard, I think there's a large applause that goes to having a conference like this, because we're able to bring this information, our thoughts, our different backgrounds, our concerns, solutions together. And I think that's really important. And so I'm happy to be here and be a part of this, and I'm very excited to see that the city of DC is putting together a conference, or has had this conference, so that we can have these conversations.
So I echo all the statements that you guys have made. I think you asked what one thing that we should probably do before leaving today. I think there's so much information in this room, so many strengths. I think it would be really unfortunate if any of us left without 10 new contacts, from someone that's sitting next to us or across the room, because there's just so much wealth of information here today. It's pretty incredible. And I think just continuing to work with just our community partners. I think we're all doing the same work, and I think sometimes we're seen as competitors, but we're really actually doing all the same work for the same group of patients. And so I think continuing to work together, share best practices is really important.
So I would think about it from different aspects of viewing the same thing. First, at the community level, I would make the assumption for anyone here who cares for patients that prenatal care begins before pregnancy. By the time we identify anything at 8 weeks or 10 weeks, that fetus is already imprinted in its environment. So simple things like nutrition, health, smoking cessation, those are all sort of social things that we have to look at as a part of the continuum of prenatal care. And so we tend to jump in once they're pregnant, but the identification and the building blocks should come before that. And so the very simplest folks who are not complex, obstetricians and so forth, that can be done at that level. For our community of providers, I will say again, I speak from just my experience being in DC. Since I've been here for 3.5 years, I have yet to ever gotten a phone call from just a provider picking up a phone and saying, hey, I have this patient in front of me. Let me run something by you. We go through so many formal channels, and if you think about it, by the time we go through a formal channel, weeks are lost, get into an answer, and pregnancy is a continuum. 3 and 4 weeks later is really 3 and 4 weeks later. And so I think as colleagues, we ought to be able to collaborate more. We ought to see each other's resources, pick up a phone, make a phone call, and we go from there. I know that with Dr. Fries's group, or even with the folks at Children's Medical Center, when I find something in a fetus, I call them right away, and we have a discussion. We may not have a solution, but we're going to have a discussion and a plan that lays that out. So I think we need to be more collegial. We need to see each other as truly resources and not just say this has to go through an official chain, write this, and then it gets shoved down the line, because sometimes you refer patients, you don't know if they ever got there. If they're in front of you and you make that call, we have a process, and then I would know whether or not they got there. So I think we need to be more collaborative. For the payer side, for the insurance companies, I'm going to say access is great. Ease of access and ease of processing has to be better. I do know that I have seen patients here whom I need to put them on McKenna, and someone else out there is processing it, and it's going through a pharmacy. So instead of my being able to say today, tomorrow, I am waiting days. We have to be better, and we know that we're on the same side. So there's a way that we process the system. So we have to make it easier to take care of that patient in many ways. So I think a lot of it comes down to the same thing. It's identification beforehand, that it starts before you're pregnant. It's collaboration and collegiality. We have a big group in the D.C. area. We ought to be talking to each other informally to set things up. And from the payer system, again, I just think we ought to be and make sure that we're identifying the things that we need and making it easy to get to them.
Thank you. So one final question for the panel. We've heard a lot today about really focusing on intervening across the continuum of care before, during, after pregnancy. We've heard a lot about the really requirement to partner with community-based organizations, address social determinants that impact quality of care and health outcomes. I want to get just a little bit more clinical, since we have 4 clinicians here. We know that preventing preterm births is a major challenge, not just here in the district, but across the country. There are established practices that we know work to prevent preterm deliveries. So just so that everyone in the room knows, what are those? And why is it that women aren't receiving those? What can we do, either on a practice level, policy level, to make sure that everyone gets access to that standard, that level of care? Maybe Dr. Meadows, I'll start with you.
Sure. One area of focus that's near and dear to my heart that we've been working on for a while is work around preterm birth prevention. And what makes it difficult is knowledge in the community about some of the interventions, trust in the healthcare system that when these interventions are offered, whether people feel comfortable moving forward with it. And then the third, when it comes to tracking progress on how we're doing with something we're trying to improve upon, we don't have very good ways of tracking. And there are other barriers that are difficult too, and one that Dr. Mighty just mentioned, which especially regarding McKenna or 17P progesterone, 17-OHPC, getting that covered, especially if it requires a prior authorization. And so some things that we think about in our group that we work through this work. So when it comes to preventing preterm birth, I think about progesterone. So whether that's progesterone for someone who's had a prior preterm birth who's getting an injection, or progesterone for somebody who's in a current pregnancy whose cervix is short, and we're trying to help make sure that their shortened cervix doesn't lead to a preterm delivery. So that's the progesterone. Then I think about aspirin, because aspirin goes towards this protection of cardiovascular risk. It also can help to prevent and protect from the development of preeclampsia, and with that, possibly another preterm birth. So we can go about aspirin with preterm birth prevention. Low-dose aspirin, having the correct dose, not having pharmacists not allow patients to fill their prescription. I've had patients who've come back and said the pharmacist did not allow them to have their aspirin prescription because of the fact that it was not indicated as safe in pregnancy. And so that made some things difficult. I think about group prenatal care, and when I think about group prenatal care, I'm thinking about supports and education. Sometimes that can also come from having a doula and having that support as well. And so I think that making sure that that's something, a message that's out there, and that we have access and resources for that. When I think about preterm birth prevention, I also think about making sure that women know that we can intervene and help to support when it comes to maternal mental health issues like maternal depression. And that's very important, because that is something that for me has not been low-hanging fruit, because of the fact that when we can diagnose or identify that there weren't very many supports for treatment and for therapy. And so that's been something that has been tough, but once we can deal with that, dealing with any of these issues in a current pregnancy also is dealing with these issues in the subsequent pregnancy. And so really establishing that relationship and building the trust. And so those are the areas that I think about. The last one that I'll say is contraception. And so the ability to think about what contraception can help to plan a pregnancy. And when I say contraception, I'm not only talking about hormonal contraceptives. I'm talking about anything that allows you to move forward in your life while not becoming pregnant at a time that you don't want to. So it could also be an educational, vocational activity that you're involved in. It can be the appropriate counseling for what are ways that you can make sure that when you get pregnant, it's when you want to, and that it's not mistimed or unwanted or unplanned. And so with that said, those are the areas that I think about. And one specific policy that comes to mind is the ability to have in an area in a health system for us in a state, something we've talked about, are a couple of things. We talk in Massachusetts about having enhanced reimbursement for group prenatal care to encourage providers to have that infrastructure set up in their hospital systems or in their clinical settings to offer this to women, because it is not easy to implement and maintain without that financial support. And the second thing that comes to mind is having a streamlined process for something like progesterone. And so when you think about McKenna having either no prior authorization or having a single prior authorization so that there is no difficulty in the way that the prior authorization has to be processed.
Unfortunately, we are out of time, but
She said it all.
But please join me in thanking our excellent panelists.
Good afternoon, everyone. So how have you all enjoyed the summit thus far? Great. We are overwhelmed by the response for participation in this summit. And as the mayor has indicated, as well as Ms. Jarrett and Ms. Hughes and many of our other co-hosts, mayors and presenters and panelists today, your attendance here today and your commitment to staying throughout the summit is indicative of how critically important the issues facing our moms, babies, and families here in not only the District of Columbia but the nation are. Today is a sentinel moment for us here in the District of Columbia. It marks our journey to this point and also helps to launch what we're going to do moving forward. So many of you have been anticipating the next steps, and we've talked about convening in October, and I'm here to just kind of give you all some context for what's been happening in the District of Columbia to date and to tune you in terms of what we're going to be doing next. If we were in the other room, you'd be seeing some wonderful graphics at this time, but you won't. So just use your imagination on this journey with me as we talk about the next steps. One of the things that we'd like all of you to do is to be very familiar, if you're committed to this journey of improving perinatal health outcomes in the District of Columbia, is to familiarize yourself with the DC framework or strategy to improve perinatal health outcomes. We affectionately refer to it as the bubbles because its first iteration about 3 years ago almost looked like a teething ring, so to speak, or bubbles. And that framework, as we highlighted it at the beginning of the program today, has 7 core tenets. You've seen it around on the kiosks, you've seen it around, but it's also described in far more depth in the perinatal health report that the Department of Health released earlier this year. We'd like you to explore that perinatal health framework that begins with the core component that every girl and woman in the District of Columbia would be in charge of our reproductive health, and it moves in a clockwise fashion and emphasizes things such as the improvement of clinical care, ensuring that every woman and girl has access to high-quality, equitable health care, and ensuring that our families have access or live in environments that are safe, and ensure that every mom, dad, and dad have the resources they need to ensure that their families can thrive. We've also been committed to asking one key question. Ms. Jarrett highlighted this as one of the things that she is really enthusiastic about here in the District of Columbia. The One Key Question campaign has been launched at all of our school-based health centers and in the Healthy Start participating programs in the District of Columbia. And the core tenet of the One Key Question program is to, what we like to say simply, ask a woman if she plans to get pregnant in the next year or have a baby in the next year. And depending on her response to that question, it was intentionally designed to be a question that could have a binary response, right? Yes, no. We find that some people say, I don't know, which opens up a different set of opportunities for dialogue between the provider who's asking the question and the respondent. If a woman says, yes, I plan to get pregnant, it's an opportunity to ensure that that woman is in her best state of health prior to conception. So if the woman has chronic health conditions, making sure that those chronic health conditions are best managed before conception. If she is a smoker, ensuring that she has a plan to quit prior to conception. All of the things that we know would put her pregnancy at risk, or things that we want the woman to begin to do in order to ensure better birth outcomes, starting prenatal vitamins, all of those things. If the woman says, no, I do not plan to get pregnant in the next year, it's an opportunity to talk about family planning options and things that Dr. Meadows just highlighted in terms of what contraception really means for a woman and their partner. The other things that we've been busy with in the District of Columbia, and Mayor Bowser has highlighted this throughout the day, is promoting women's health and well woman visits. And we're doing this now through a media campaign. Have any of you seen the media campaign? The one in particular that we have is a woman traversing, she's on a bus that's been zipping all across the city, and she's got this pretty cool pose, like she's taking a selfie. That one has been really popular, at least she's around the parts of the city, which is not much canvas that I don't cover as the health director, but she's been crossing and zipping across the city, and her tagline is, a well woman is a determined woman. Because we recognize that, and Dr. Mighty has emphasized this, so much about a healthy pregnancy begins before conception. It begins before the woman is pregnant. And so we've really focused on the concept of women's health overall and promoting a well woman's visit. We also recognize that if we promote well women's visits, that's not me, right? Okay. Promoting a well woman's visit, it increases the opportunity that we can have to ask that one key question. Another thing that we've been busy doing here, and I don't know if Vince Keene has made it back to the room, but I did boast that I was going to be showing pictures of his health centers at Unity Health, so tell him I did that. Even though I don't have the audio visuals, but we've made significant investments in our health infrastructure in the District of Columbia, and we'll continue to make those investments, including the building of a new state-of-the-art hospital in Ward 8. And one of the things that we've done, if you look at the comparison of some of our federally qualified health centers over the past 10 years, and the before and the after pictures are astonishing in terms of the quality of these facilities, the state-of-art nature of some of these facilities in just a 10-year span. And it's not just about the innovative appearance of these facilities, it's also increased their capacity in terms of who they can serve. And they have been able to expand their hours of operation, being able to meet families and residents where they are, being able to accommodate the working family in a much more comprehensive and robust way. And we've been listening to residents. We've been listening to residents, and we've been seeking first to understand why we have some of the challenges that we have in the District of Columbia. When I returned to the District of Columbia in 2015, it was a bit sobering after having been the Senior Deputy Director of the Community Health Administration to see some of the statistics that we were still faced with in terms of the percentage of women who were entering prenatal care in the first trimester and the percentages of women who received no prenatal care their entire pregnancy. It was also a little bit sobering to see the number of women who did not have adequate prenatal care for their entire pregnancy. And you see these things and you want to know, well, why does this occur? In a city where 97% of the population has been insured for quite some time. And we're not just talking about U.S. citizens, we're talking about our entire population. So this is something that we can boast about, and it speaks to our DC values and who we are. Because unlike some other states where they insure pregnant women, we insure women when they're not pregnant. So we're not just talking about providing you insurance while you're pregnant, that insurance goes away after the postpartum visit. You're insured even after that last postpartum visit. And so we really wanted to understand, we did some focus groups at the Department of Health to really understand what the issues were related to, and both Maria Gomez and Kelly McShane talked about this in the first panel, that these issues of implicit bias began to come up, these issues around the cultural competency of care began to come up, and these issues around customer service began to come up, amongst a host of other things. But we also know that the DC Primary Care Association has spent an inordinate inordinate amount of time giving us some really good answers and feedback by using the human-centered design approach to really listening to residents. And so I implore you all, just as Kelly did this morning, to take a look at their product and see what they've been able to learn from residents, real people in the District of Columbia who have a lot to share with us in terms of what we need to do to improve maternal and infant health. And we've been busy. We've been busy on the policy front. So both our executive branch with the leadership of Mayor Bowser, but also our council, our legislature here in the District of Columbia has a commitment to this issue. Mayor Bowser spoke about it earlier. We had opportunity for Councilmember Todd to join us today, and we've passed a maternal mortality review committee. These issues come up where states are aggressively pushing this. This is one of the pieces of legislation that has been that people are calling on Congress to pass, but we also have a babies bill that was introduced, and we've had a council hearing on it, to be some of the effective ways that we're going to move forward and be able to have improved health outcomes for our moms and babies. So what should we focus on? You know, I've been asked this question throughout the day. We don't want to preempt the great discussion that we've had today. We've been taking copious notes. Much of this has been recorded. It will play on DC's channels repeatedly. So for those who couldn't join us in person today, hopefully we'll have the opportunity to hear some of the great things that we've heard. But we do know, prior to today's convening, that the data does give us some idea of the things that we need to focus on. And we have three core recommendations in our perinatal health report that came out earlier this year. We need to improve the health of women before pregnancy. There's a number of ways that we can do that, but that's one core recommendation that we have. We need to address barriers to early entry into prenatal care, so increasing the number of women who are entering prenatal care in the first trimester. There's a number of strategies that we can put in place to accomplish that. And the third thing that we need to do is we need to decrease the number of babies who are born too soon here in the District of Columbia. Those are the three things that we need to really focus on in order to make progress around maternal and infant health in the District of Columbia. So the last thing that I will share with you all is that you have a pledge card. Have you all identified or located your pledge card? It was one of the, here's mine, right? So you all see your pledge card. It was at your table, in your bag, somewhere. I know you have it because some people are showing it to me. And on your pledge card, the summit pledge, it says, as a result of DC Mayor Muriel Bowser's Maternal and Infant Health Summit, I will. And there's a free text space. And then you have the opportunity, if you'd like, to write your name and your email. You can either leave it here with us, or you can go online on the same website that you use to register and complete out an electronic version of this card. And then the same options you had for identifying yourself for the summit are present on the back, and we'd ask that you select one of those options. We're really interested in the commitments that you will make as a result of having attended this summit. So we'd like you to complete your summit pledge. We know many of you are not new to this work, right? You have a commitment to improving maternal and infant health. We know some of you are committed to this work, but have been going it alone and would like to connect with others. On the last panel, it was stated that no one should leave here having not networked, right? So that's the other point of the summit. We want people to feel more connected. We want to increase the power of the work. We want to be better leveraging all of the actions that occur here in the District of Columbia. And one of the ways that we're going to do that is that we're going to bring some of the existing coalitions, some of the existing groups that have been working together, get together again to digest the recommendations that have been made here at the summit on October 23rd at 10 a.m. The current location is DC Health. Depending on what we get back from the pledge cards, we may have to change that. So we're really excited to have that follow-up convening on October 23rd at 10 a.m. We're really looking forward to hear all of your feedback, your commitments that you are going to make in your pledge cards, and we're really excited to continue to move this work forward. So on behalf of Mayor Bowser, the entire team at DC Health, we thank all of you for your attendance today here at the summit. We look forward to continuing to work collaboratively with all of you to improve the lives of moms, babies, and families here in the District of Columbia. Columbia. Thank you and enjoy the rest of your day.